all the colleagues, friends, and state officials, subject matter experts, quality and patient safety experts. I'm Dr. J.M. Srivastava from National Health Systems Resource Center. And it gives me an immense pleasure, and it is my privilege to welcome Dr. Subhrajyoti Bhaumik. In fact, Dr. Bhaumik is an old colleague, and last year he was the part of the eminent speakers galaxy, which had joined us on the last Patient Safety Day, World Patient Safety Day last year in the 2020. And believe you me that many, in fact, the people, and his lecture was liked very much. And we are really grateful to you, Dr. Subhrajyoti, for having consented to be with us and to talk to the state level functionaries, hospital level functionaries, that what can be done, what is the extent of the harm, what can be done to mitigate the issues, patient safety related issues pertaining to the medication. And Dr. Bhaumik, in fact, such a, considering his, if I look at his CV, which I looked, and his experience, it is a phenomenal. Like he's a basically medical graduate, having won a gold medal. Subsequently did the advanced qualification MD in pharmacology. Then also he had been, in fact, continuously learning, teaching, and working for the larger cause of the medication safety. He's has got a qualification in clinical endocrinology. Then there is some qualification in the research administration, project management from the renowned institutions like Stanford University, then St. Hopkins Institute. He's also a assessor under NABH assessment system. And during COVID, in fact, he was the principal investigator for the Sputnik vaccine, which few of you may recall that it got rolled out in the, as per the Government of India guidelines in certain corporate hospitals. And also he tested the many antiviral drugs, also the efficacy of the ivermectin, doxycycline, because imagine during that time, all of us were struggling and trying to figure it out, that what will work, what will not work. Besides, he is a fellow of ISQA, that is International Society for Quality in Healthcare, has got many, in fact, the publications to his credit. Besides awards from Confederation of Indian Universities and UK State Oration Award, and one of the most promising healthcare professional and young achiever. Short stint also he had the patient safety in the patient safety unit of the WHO headquarters. Besides all these achievements and other things, currently he is the clinical director of academics of the medical quality and the clinical research at PLS Hospital, Calcutta. So we have got such an eminent person to talk to us today, and I won't stand much between you and Dr. Bhaumik, because you have, there are about, say, 530 odd logins are already there. And believe you me that in one login, there are 2-3 people, like over here, that NHSRC. So it may appear that there is a single login, but we are 7 of us sitting all together. So it is a huge participation. So Dr. Bhaumik, it is all yours. Thank you very much, and once again for being with us and taking the time out of your busy schedule to orient the participant on the importance of the medication safety. Thank you once again.
Thank you, sir. Am I audible, sir?
Yeah, you are audible.
Okay. Thank you at the outset to NHSRC, to Dr. Srivastava for believing in me and inviting me once again. The tremendous work done by Government of India under NHRC and the leadership of Dr. Srivastav. I salute you, and this is a great occasion for me to be invited by the coveted NHSRC and talk about my limited experience on medication safety. Where I would like to share my slides, which I am going to talk today. Please let me know if my slides are visible. Dr. Sushant, Srivastava.
It is visible to us.
Okay, thank you, sir. Thank you very much. So medication safety, I think I must first thank the organizing committee that among the patient safety, they have really focused on medication safety. And today we are going to see why medication safety is important. And all of you, all my colleagues who are joining from rest of the parts of our country, you all are doing great work in the nation. But let me just highlight few areas which we need to be very careful when we are dealing with medications. This is extremely important. So all of us, the doctors, the nurses, the pharmacists, the basis of treatment should be this slogan, which is in Hippocratic Oath, primum non nocere. We should never do harm to the patient who walks into our hospital. And this is not only the basis, the mantra of patient safety, this is a mantra of medication safety also. And one can definitely think today at the beginning of the presentation, how do medications affect patient safety? Why has Dr. Srivastav taken so much effort to have this session on medication safety? So the answers are that the medication safety issues can range from adverse drug reactions, and as Dr. Srivastav was mentioning, that COVID-19 has been the most difficult time in the healthcare which has been witnessed in the last 100 years, where we have new medications, we had new vaccines. All of you are doing tremendous work in rolling out the vaccination program in the country, and salute to all of you for fighting the COVID-19 pandemic. Now, a lot of these drugs were used for the first time in COVID-19 patients. So adverse drug reactions, the adverse event following immunization, people are concerned. So this is a very important medication safety issue. Use of hazardous drugs, we all use, some of the hospitals use narcotics, some of the hospitals use chemotherapy agents, and we all know these are drugs with low therapeutic index. That means the dose which produces the effect and the dose which produces the side effect, the window is very narrow. So this is a major issue which we need to focus on. IV infusion. Every patient, every second patient in the hospital who is admitted requires IV infusion. There are a lot of IV infusion safety issues, and today medication safety, I've been asked to do justice to the session by only speaking for 1 hour. And let me tell you, there are, for IV medication safety programs, we have training programs ranging for 2 to 3 days. So I will just highlight few of the issues there. There are many hospitals who are treating with radioactive drugs, and radioactive drugs are not only dangerous for the patients, but they are very equally dangerous for the healthcare providers as well. So we need to ensure that not only the patients are safe, the healthcare providers are safe. And I call upon NHSRC under the leadership of Dr. Srivastav that healthcare worker safety should be another session going forward on what we need to do as healthcare workers. And last but certainly not the least in the list of medication safety is the medication error. And this is the major issue why people focus on medication, because litigations happen across the world, including India, where medication errors are brought into the notice as a reactive phenomena and not as a proactive phenomena. And let me just talk about what kind of horror stories are reported in the country. And don't think that I am pointing out to a particular state or to a particular hospital. These horror stories are reported from every part of the country. In this young mother who had just given birth to a child had to die because one of the patients, one of the nurses gave her an injection which was supposed to be given not in the intrathecal route, but to be given on the local. It was a local Ferilium, was a local medication, and it was given an intravenous dosage. And this is a sad story that the lady who was admitted in the gynae ops ward and was supposed to go home after 2 days, that lady, after getting the intravenous dose, died. And we look at these kind of reports, we say a prayer in the name of the lady, and we think about the child who lost the mother without even getting to know what her mother was. And then we move on in life. Do we need to do that? Can we build safer system? And that is what is medication safety. Medication safety is the freedom from accidental injury due to medical care or medical errors used during the medication use process. It requires same prioritization and is and should be given the same scope of use in patient harm and frequency and severity of potential harm. And this is a major issue across the globe. And if you really look at that, how important is medication safety in the world, the WHO, the World Health Organization, which leads all the countries in focusing on areas which are killing patients or in patient safety areas, called in for the first challenge of clean care is safer care in 2005, which was all about hand hygiene. In the 2007, second challenge was called by WHO, Safe Surgery, Save Lives, and that resulted in the birth of the surgical safety checklist. And the current challenge, ladies and gentlemen, which has been launched by WHO in 2017 is Medication Without Harm, which is dedicated to medication safety. And it is an unfortunate 5 years, I would say, where COVID has ravaged us since 2019, that not much work has happened in this challenge, but we need to put a lot of effort in this. And I got a lot of, as Dr. Srivastava was mentioning, I was very lucky to visit the patient safety unit at Geneva in WHO. And I could see the level of work which was going on for this third patient safety challenge. And I'm sure that once we have COVID under control, NHSRC can roll out. I'm sure NHSRC is doing a lot of work as well, can roll out this patient safety challenge in the Indian hospitals. So medication without harm is the mantra. And how do we do it? We do it by reducing medication error. What is the medication error? It is a preventable event that may cause or lead to inappropriate medication use or patient harm when the medication is in control of the healthcare professional, patient, or consumer. Now, extremely important that the consumer may buy a lot of medications over the counter and come to your hospital with the error. It is very important to note these errors, very important to document these errors, and very important to implement appropriate corrective and preventive action. This slide is a known slide, and I'm sure if you have been attending the first lecture, even Dr. Srivastava mentioned about this, that medication errors are killing. They kill more people than what motor vehicle accidents or HIV patients die altogether in the United States. It is considered a worse than a crime, and if it is reported, it results in a lot of malpractice litigation, particularly if it is not reported in the right way. So this has resulted in a lot of these errors result in a lot of serious economic consequences like extended hospital stay, additional treatment for the patients. And as a result of which, what is extremely important is that the WHO has called in for the countries to come together and launch the Medication Without Harm program. Just look at that figure, which is highlighted in red. A total of 0.7% of the total global health expenditure, which is roughly around 42 billion US dollars, can be avoided if medication errors are prevented. And this is the WHO World Bank report, which is talking and staring at face that errors are costing us heavily in the world. What is the scenario in India? Now, let me tell you that Indian scenario is not different, but Indian scenario, we have sketchy data. One of the largest study which is done in Indore, in Madhya Pradesh, it is in the pediatric intensive care unit of over 1,200 children. It shows that 457 errors were identified and medication errors were 68% of them. And majority of the children errors are due to dosing errors. Luckily, they did not have majority of the patients with morbidity, but 11 patients of these 1,286 patients had severe errors resulting in prolongation of the stay. So why am I talking about these things? Why am I showing you these data? Is that you at your own center should not only document your data, but go ahead and publish your data. What is the other? This is another study coming in from the state of Gujarat. Big prospective study in the teaching hospital in Gujarat, over 1,100 patients, medication errors, 36% of them. The most common prescribing error, 65% of them is prescribing error, followed by 31% administration errors. Majority of the prescriptions are semi-rational. Now, very, very important thing that we need to monitor, we need to guard our prescription, and the pharmacists and the clinical pharmacologists have to be involved now to monitor the prescription. Prescription audits are one of the safest tool, one of the most efficient tools to prevent prescription errors. Now look at this. 30% of the prescriptions are irrational. We are prescribing irrational medications, irrational combination to our patients. And this is a teaching hospital in one of the largest states in the country. So we need to be very, very careful. Now, did we do any research on this? Yes. This is our research from Eastern India. This is one of the largest studies reported till date, a 3-year study on 50,000 patients. And we found out that around that reporting of errors at our hospital was very, very less. There were only close to 100 errors which were reported. And one of the major problems with medication errors is that people don't want to report it. People think that there will be a lot of retaliation. People think that if we report, we might lose our jobs. So yet I would say that we need to keep on reporting our errors and do appropriate corrective and preventive action. The medication errors, which are the main pillars of what we need to avoid to ensure a medication safety culture, medication errors are costly to the patients, the patient families, the patient employers, hospitals, because if the hospital's average length of stay increases, then the hospitals don't make money. The hospitals lose money. And in a country like India, where we have such less number of beds, we need to have more turnover of beds, and so that we can take care of more patients. It affects the doctors, it affects the nurses. There is something known as a second victim phenomena, where the people who are involved in errors, they suffer from lot of lack of confidence. And it's very important that we don't perform a second victim phenomena and we counsel the second victim. And of course, the insurance companies, especially important in case of private healthcare, they will not take care of these extra costs which the medication errors bring in. Now, ladies and gentlemen, which is the population which is susceptible to errors? If you are working in the ward with children, please remember you are subjective to high errors, because it's a difficult, children dosing is difficult. Children don't speak, they don't communicate properly, we don't know the history. Aged patients about 65 years of age, physically challenged, patient receiving urgent and life-saving care. Now, this is in case of emergency and ICU. So if you are an ICU nurse, be very, very careful that you don't get distracted when you're preparing your medications. Patients undergoing high-risk surgeries, patients on multiple medications, so geriatric patients, very common for them to get an error when they are going back home or when they are changing when the reconciliation is happening from one care unit to the other care unit. Patients with multiple medication allergies, now non-English speaking users, I would say in our country, non-vernacular speakers. If I am a patient in Tamil Nadu, I don't know Tamil. I will not be able to speak Tamil, and even if I speak Tamil, I will not be able to speak properly. So I'm at a high risk of developing errors, and anyone who's being discharged from the hospital. The reason I put up this list is because these are the checklist which a hospital or a healthcare unit should have when audits are performed, whether they are performing errors or not. What are the common causes of errors? The most common cause of errors are human factors and system factors, abbreviation, oral orders, look-alike, sound-alike medications, dosage calculation, high-risk population, and at risk. Now let me describe, and you will keep on seeing this reasons diagram again and again during the patient safety week. What this diagram clearly shows is that nobody is at fault. The faults are lying at the different levels of the organization in which we are working. So imagine a night where a new doctor or an intern is giving a round in the emergency or is in duty of emergency. He forgets to take the history that the person is allergic to penicillin, and the patient is prescribed penicillin, and you have a new nurse who is taking care of 5 patients, and she forgets the history as well. The prescription is sent to the pharmacy does not check, and this comes back to the nurse, and the nurse administers the injection, and the patient has anaphylaxis reaction due to the penicillin. Now, whose fault was this? This was not fault of the doctor. This was not fault of the nurse. This was not fault of the pharmacist, or I would say this was the fault of all the three. Or rather, it was a fault in the system which resulted in the hazards to come in one line and reach the patient. So medication errors signify faulty system always and not faulty professional. Now, human factors which result in medication errors, mental slip, all of us are doing, we are very disturbed in the COVID-19 phenomena. We have lost our near and dear ones in the pandemic. Too much of information, too much to process, and too much to give. So there are a lot of poor handwritings. We don't understand. We are under stress, and a result of which we are interpreting a wrong prescription. We are administering a wrong drug. And this results in the errors. Again, I would say the errors or the risk to reach the patient. Now, very important is that the environment of the hospital or the environment of the healthcare unit has to be proper. It should be away from distraction, noise, heat, clutter, motion, and even in the ICU, when the alarms are going on continuously, there is known as the alarm fatigue, as a result of which people are not able to concentrate on the dosage schedule. So what do we need to do? We need to have dosage schedule, pre-formed dosage schedule in ICUs for the common drugs. And extremely important that the shift changing, we must document the handovers in a proper way. What kind of medications the patients are receiving, what kind of allergy these patients have. These handovers have to be in a proper documented way. The other important aspect which we all have to take care at our healthcare units is the look-alike, sound-alike drug. India is the generic capital. We have, for one pregabalin molecule, we have 30 brands. For one piperacillin tazobactam, we have 60 brands. So maybe it is less in the government because government supply is controlled. But we must have our own look-alike drug list, and if you are an NABH accredited hospital, you know that the assessors are going to look at your look-alike drug list, and this look-alike drug list should be of your hospital, not of Pados ka hospital. You cannot do Control C and Control V and prepare a look-alike list because it is not going to help you. So it should be of your hospital. I will give you some examples. The look-alike, the one which is there, or the sound-alike drugs, Diamox, Zymox, Glyinase, Zinase, Incidel, Inderil. Thousands are there, but only small are reported. Now look at the Xyloric, Buscopan, Weltam, Pantium. These are very, very important look-alike medication. Now, many people tell me that, sir, please give me a look-alike medication list. Look-alike medication has to be prepared by the store and the pharmacy sitting together, because it is extremely important for you to understand how these molecules look. It is not every hospital, it is going to be unique because the look-alike medications are different. Now look at this very unfortunate story. It has been published in the Indian Journal of Anesthesia. The bupivacaine injection looks like the tranexamic injection. Bupivacaine injection is used in spinal anesthesia, whereas the tranexamic injection is used as a clotting agent to prevent further bleeding. This unfortunate patient who had to be given bupivacaine because she was undergoing cesarean section was injected tranexamic acid into her spinal cord because the anesthesiologist was managing 2 OTs at one point of time, and result of which the patient, the young mother, suffered from total paralysis of both lower limbs. So be careful before you give the injection. Every unit, every hospital should have a high risk or a high alert medication list, which have the heightened risk of causing patient harm. They should include at least the neuromuscular blockers, the insulin, the opioids, the anticoagulants, the chemo agents, concentrated electrolytes, the IV adrenergic antagonist, theophylline, and so on and so forth. Some discussion on spurious drugs. Extremely important in a country like India, where 10% of the Indian market drugs are spurious. So they look like, absolutely, they look like the original drug, but they are not original. So you need to be very, very careful. And the pharmacists in this country, they cannot work as a dispensing machine, because if that is the scenario, then day is not far when they will be replaced. They have to understand quality control. They have to understand ISI marks. They have to understand copyright of the logo, and also undertake batch testing. The hospital pharmacy has a big job to do apart from just dispensing medication. Abbreviations can kill because we all innovate our own abbreviations. And this is dangerous because if you don't have a list of abbreviation which is allowed in your hospital, it is going to be very dangerous for your patient. So please stick to standard abbreviation. I'll give you the example. HCT is hydrocortisone, which is a steroid, or HCT could be hydrochlorothiazide, which is a diuretic agent. So now imagine, in case of a diuretic agent, if a steroid is given to a patient, it will produce increase in the blood glucose level. The last example is even more dangerous. Zidovudine is AZT. It is used in case of HIV patient, but AZT is also used sometimes in certain hospitals for azathioprine. Azathioprine is an immunosuppressant patient. Our HIV patients who have immunosuppression, if they are given zidovudine mistakenly, imagine the plight of the patient already who is having an immunosuppressant. He or she, after receiving zidovudine, will be on the verge of death. We need to classify medication errors, and the errors are prescription errors, administration errors, transcription errors, and dispensing errors. Now there could be intercepted errors and actual errors, and a good hospital is one, the good hospital is one which has got intercepted errors or near misses. So we need to develop the reporting system the incident reporting and learning system. So reporting only will not help. We are reporting errors. When I go for NABH and accreditation survey, I see heaps and heaps of data. हम तो इसको collect कर रहे हैं. We are collecting this. But आप analysis क्या कर रहे हो? Analysis करने के बाद, what are the corrective and the preventive action you are taking? That is the most important thing, because you want to make the environment safe. You want to contribute to medication safety. Now, a good hospital or a healthcare unit should perform a proper RCA or a root cause analysis of the medication error. And this is the Ishikawa diagram, just an example of the fishbone diagram of if there are prescription errors reported, what could be the cause? Was the order illegible? Was the drug changed without discontinuing the previous one? Was the order without the time interval? So you have to at least look through every possible mechanism, ask 5 whys and do beautiful representation of the root cause analysis and discuss it with the leadership team and also frame the corrective and preventive action. This is in our hospital. We are using a very simple form to report the medication error. And you, I'm sure you also have, you must have something in which you must report, analyze, and implement appropriate and corrective action. Now, there is a very close association between medication errors and the adverse drug event. Some of the adverse drug events are medication errors, but not all adverse drug events are medication errors. So some of the adverse drug events which are not medication errors, this portion is adverse drug reaction. And that is known, so if we capture adverse drug reaction, the science of it is pharmacovigilance. And I congratulate the government of India for running the National Pharmacovigilance Program, the Pharmacovigilance Program of India. And the reason why we need to undertake pharmacovigilance in every healthcare unit is that whenever a drug is developed, the safety data is only limited in less number of people. So we have to get the safety data in the larger number of people, and to promote rational use of medication, every hospital should undertake pharmacovigilance activity. And you must have a pharmacovigilance cell. You must use the form of the government of India, which is beautiful form, which is an extensively well-developed form. And the reason why you need to do pharmacovigilance is because pharmacovigilance is costly, or ADRs are costly. There is an average cost of $2,262 per ADRs in the United States. And this data is as old as in the year 2013. This has gone up to at least $3,000. In India, very less data in India, but the paper, this is a paper which is from KEM Mumbai. In India, one ADR can cost us close to 6,000 rupees. Again, the data coming in 10 years back. So this must have increased to 12,000 rupees. I call upon NHRC to undertake these pharmacoeconomic studies in the country, which are extremely important. Now, ADR people are just capturing. What is the most important thing after you capture the ADR? You have to do the causality analysis, whether it is related or non-related. You have to use two forms, two methodology. WHO Uppsala Monitoring Causality Scale or the Naranjo scale. If you use the WHO scale, there are certain questions which can categorize your ADR as certain ADR, probable, possible, unlikely, conditional, or unclassifiable. So even if the medication appears to have caused an ADR, the questions in a very scientific way can prove that whether it is certain or unclassifiable. And this usually should be done by the pharmacologist or the pharmacist. This is the Naranjo's ADR scale, a beautiful tool which we are using in many of our hospitals. And I request all the participants to please implement Naranjo's classification scale after you have reported an ADR, that you classify the ADR according to highly probable, possible, and doubtful. So Sometimes the ADR might happen, but it might just be possible or maybe doubtful looking at the scoring system. We have done this and we have published our data in the country. And this is a very simple study on adverse drug reaction to non-ionic contrast medium in the radiology department. 1 year experience, more than 3,000 patients, 3,700 patients. And we have found out that the government approved non-ionic contrast dyes, they are very safe in Indian patients. This is extremely important to understand what is the adverse event of these radiological ionic dyes in our country. This is another effort which we have done in a large teaching hospital in Kolkata. It is the SSKM hospital, where the psychiatry patients' ADRs were monitored. And this is a very interesting paper where we have found out that after screening 2,000 patients, we have found out that majority of the ADRs are related, and some of the ADRs were found to be very common in the Indian population, which has been not reported in the Western population. So please perform the ADR causality analysis. The second part of my presentation will be on few tips on how you can prevent medication errors in your setup. So at the doctor's level, I think the most important thing is every doctor should be motivated, should be asked to write the prescription legibly. My handwriting is very bad. And that is the reason I agree that sometimes my handwriting cannot be read by many people. So I write in capital letters. Let us have a capital letters policy. The government of India, the erstwhile MCI, and now the NMC wants all the teaching hospitals to write medication orders and prescriptions in generic name. And this is very, very important because the many pharmacists don't understand what is the brand name. So dose, strength, direction, with dose, strength, and direction for use. Now, verbal order policy, you have to understand whether verbal order drugs have to be allowed or not allowed in the hospital. In our hospital, we have only allowed the life-saving drugs to be given through verbal orders. We don't allow any other drug because it's a very common method of doing medication error, of indulging in medication medication error. So please implement your proper verbal order policy. All ICUs should have protocols for high-risk medication, as for example, anticoagulant usage. Please develop these protocols beforehand so that the new intern on duty, the new doctor on duty, the new nurse on duty does not have a confusion and ends up giving the wrong dosage for a high-risk medication. We must have a standardized abbreviation list, and it is difficult for doctors to adhere to this, but we have to keep on harping, keep on doing the prescription audits and to ensure that the standardized abbreviation and acronyms are used in the organization. Hospital formularies are present in government organizations. They have to be implemented and in the 2S form, and NABH wants this implementation as well. Some of the hospitals have implemented tall man lettering to emphasize the drug name differences. As for example, the prazole is common in rabeprazole and aripiprazole. Rabeprazole is a proton pump inhibitor. Aripiprazole is used in antipsychotic. But the prazole portion, whatever is common is not highlighted in capital letters. The portion which is not common is highlighted in capital letters. So this can be a strategy, a tall man lettering strategy. And definitely the pharmacologists have to be involved in regular prescription audit followed by appropriate corrective and preventive action. Do they help? Yes, they help. This is our own study in 2020, of course, done in 2019, that we have screened over 6,400 prescriptions in 6 months, and we had shared the audit report with the clinicians every month with regular training of good prescribing practices. And it has improved the prescription audit, the prescription quality. Hence, regular prescription audit followed by dedicated clinical pharmacology team improves the quality of the prescriptions generated by the clinicians in the long run. This is an example of the oxytocin infusion regime which could be present in your labor room. At the nursing, I think I salute the nurses because they are the backbone of any healthcare. So salute to you. I think you are doing wonderful job, but many a times the problem with nursing is that there's a lot of attrition, especially at the private sector, not much in the government. Government, of course, transferable jobs. So nursing has to implement some basic things. Label your medications before you prepare all the medications and labels to be verified by 2 qualified nurses before administration. Not more than 1 medication is labeled at one time. And medications which are found unlabeled should be discarded. ये normal saline हो सकता है, white liquid ये हो सकता है, nothing as हो सकता है. You have to throw it. If you don't know what is it, it can be hydrochloric acid also. It can be sodium hypochlorite. It can be normal saline. So we cannot take chances. We need to continuously train our staff, and nurses are very good at training. We need to train our staff, train our nurses on LASA, high-risk medication, medication error reporting, pharmacovigilance. Separate storing of LASA and high-risk medication in the hospital has to be undertaken. So these are the examples of how 2 different nurses can actually sign high-risk medication, cefazolin, which is considered as a high-risk medication because of its high allergic potential. The nurses have signed here together. Proper label by the nurse, beautiful label with what kind of drug is being mixed, who has prepared it, and what is the time for preparation. The drugs labeled in different medication racks so that in a hurry you don't pick up the wrong medication and give it to the hospital, to the person who's helping you. The one of the very commonly missed link in the medication safety culture is the pharmacist. The pharmacy, we have to ensure that dispensing is done by competent individuals. Many a times the pharmacists are not dispensing it. They are dispensed by non-pharmacists. Let's stop that. They have to know the storing of LASA and high-risk medication. There is no reporting culture at the level of pharmacy in many of the hospitals. Wherever I have gone, I have implemented it. It's a continuous process. We need to keep on hammering, as they say. So dispensing errors have to be captured at the pharmacy level. Indenting errors have to be captured at the pharmacy level. We need to train this group. This group is one of the most neglected groups in the healthcare medication safety chain. They have to be involved in hospital formulary development, and they have to get trained on good pharmacy practices. Now, last but certainly not the least, the most important stakeholder is the management, or I would say the leadership. And the leadership should ensure that there is a blame-free, punishment-free culture of error reporting, and which is medication error reporting, ADR reporting, because punitive action is not an effective way to prevent recurrence. And this we know across the globe that punitive action can never reduce error. Medication errors, ladies and gentlemen, I have been saying from the first slide that does not signify faulty professional, it signifies faulty system. So the management level or the leadership has to take total care that the faulty systems don't exist. The management has to ensure that the voluntary reporting system and learning systems exist in the hospital or the healthcare unit, where the blaming and shaming of the individual care does not take place. You have to invest on clinical pharmacologists. These are specialists or clinical pharmacists to collect and analyze medication errors and devise strategy for process improvement. And many people say that, let us bring IT. India is undergoing the revolution, health IT revolution. Lot of things are under digital health India. Will IT reduce medication errors in the healthcare scenario? Definitely, computerized physician ordered entry can reduce error to 80%, but it cannot eliminate the prescribing errors. So the judgment of the doctor is very important. and that can only come through regular upgradation of knowledge, through regular prescription audit, and that is the crux. But definitely computerized physician order entry makes it more legible to read and reduces other kinds of errors. It also reduces the dosing errors. So to summarize my presentation today, I would say medication errors, medication safety in healthcare is a very important patient safety challenge. And this patient safety challenge has been called upon by WHO. And it is the current challenge right now, ladies and gentlemen, in the world, the third patient safety challenge. Medication errors are common in healthcare. So don't think if your healthcare has medication error, if your unit has medication error, you are a bad unit. I would say the other way. You are a good unit because you have reporting and learning system. They always result from poorly designed systems rather than negligence of the healthcare provider. Safety reporting activities for medication safety culture in the organization should include identification, reporting, analysis of the errors by the dedicated team. Because the ultimate aim is to develop a culture of patient safety and a fault-tolerant healthcare system. This is very, very important that the culture has to be fault-tolerant, and we should be open to hearing feedbacks that what is working and what is not working. And healthcare professionals, this includes not only the doctors and nurses, but the pharmacists who are working day in and day out in our hospitals. They should be encouraged to participate in a blame-free environment in the voluntary reporting system as a commitment to patient safety. So to conclude, we must always remember there are no biologically safe drugs. So as a clinical pharmacologist, if somebody says that will this drug have any side effect, I say any drug which does not have a side effect does not have any effect. So there are no biologically safe drugs. There are only safe physicians, safe nurses, and safe pharmacists. Let us aspire to become one. Let us all join hands, and under the leadership of NHSRC, let us make this dream of medication without harm, the patient safety challenge, a slogan called by WHO, a great success in our country. With this, I end my presentation. If there are any questions, I'm more than happy. I'll try to answer those questions.
Thank you, Dr. Shubhajyoti, for such a wonderful presentation. And in fact, there had been about 1,200 logins. Somebody has flagged a question in the chat box. You may like to clarify that what is the difference between adverse drug reaction and adverse drug event? So any reflection on that?
Yes, it's a very good question, and I thank the participant for asking that question. So I was mentioning about the causality of the event. So whenever we are reporting any error, we report that as an adverse drug event. Suppose I'll give an example. A patient who came to the ward and was not able to give the proper history, was allergic to sulfonamide and was given a sulfonamide. And as a result of which the sulfonamide produced severe allergy in the body, and this initially is reported as an adverse drug event. Now we want to find out if this is related to the drug or not. When the relatedness is found out, we do it with the help of tools. I mentioned the WHO UMC tool or the Naranjo's tool. The Naranjo's tool with the question will tell us what is the outcome, this reaction, whether it was related or not related. When an adverse drug event becomes related to the drug, it becomes an adverse drug reaction. So all adverse drug reactions have the causality analysis done for an adverse drug event, and the drug which is not related, if you don't have a causal association, then it does not become an adverse drug reaction. It is just an adverse drug event.
Thank you. Thank you so much. And another question, in fact, is coming up from the many participants. And we would also like to inform that NHSRC has though recently come out with the guidelines that how to conduct the prescription audit. But at the same time, since you are the subject matter expert, and perhaps you can touch upon that, what could be the start point if somebody wants to make a beginning, that how to go about in, putting somewhere a system for the conduct of the prescription audit. Though I know it is a whole lot of science and involved, but at the same time, just a couple of thoughts on the start point for the prescription audits.
Yes, thank you, sir, and thank you, and I congratulate NHSRC for coming out with the guideline. Prescription audits, I think, very important is let us look at some key problematic areas. I would recommend the hospitals to start the prescription audits in ICU. If I would be starting the program of prescription audit, I will do it in areas where there is a heightened risk of medication error. So I can do it in ICU, I can do it in dialysis, I can do it in emergency. Of course, wards are important, but slowly and steadily we will increase it from a pilot to the other areas of the hospital. Now, when you are doing the prescription audits, we look at different parameters. We look at, one is the content of the prescription. So every prescription should have an inscription, superscription. I mean, this is a separate session altogether, but is the prescription according to the method in which a proper prescription should be given? Small details like allergies captured or not. This is a very important thing when the prescription, whether allergies have been captured or not captured. The other details about whether what kind of drugs have been given, what antibiotics have been given, if their proper dosage has been given, what duration has been given, route has been specified. So I would say it's better to have a checklist. We always undertake the prescription audit through a checklist. Now, when we come through, we will of course perform with the help of a sample size. Usually, I would say through NABH, NABH says 20% of your indoor patients, ideally per month, you should do a prescription audit. That is a statistically significant number. And once you have the statistically significant prescription audit done, the audit reports should be shared with the senior management as well as with the clinicians. Of course, don't put the name of the clinician, I would say. Audit reports should be always through specialty wise, because we are not here. It's not a fault finding process. It is a fact finding process. And every audit should have its appropriate corrective and preventive action. And it is a continuous phenomenon. So once I do an audit in the month of August, I present my report in September, I implement something in October, then I have to again do a re-audit in the month of November to see whether that cycle has been completed or not.
Thank you. Thank you so much. In fact, last question, in fact, that is my question, personal, that like in the government system, the procurement is through the government machinery. So what would be the, say, the pointer when we can suspect that perhaps a drug may be spurious, because you brought out that about 10% of the product somewhere could be the spurious. So how what would be that, the red flags when we can suspect and take the further actions? You can elaborate that, and then thanks.
Very good question, sir. Very, very good question. I think first and foremost, government machinery, I would say we really are comfortable in the government machinery that a lot of checks come in the supply chain. But I think as a pharmacist of a government hospital, I should ensure few things is definitely do my batch testing, and which the pharmacists are aware of, that looking at the most important is the logo and the ISI mark. The logo of that company has to be checked. If you are, I would say, let us have a checklist. We should have a checklist at the level of on what needs to be checked with every batch. And they usually come from government approved vendors. So it is always better to do the verification of the vendors as well. And lastly, but not least, is also, sir, what I always recommend to my pharmacists with the help of the clinician is that we also do something which is known as the efficiency testing. That means when the drugs are given to for usage from a certain batch, the nurses and some of the doctors are involved to understand whether this drug is acting in reality, in the senses whether it is able to achieve the therapeutic outcome or not. So it is a completely holistic approach of not only involving the pharmacy. Initially, pharmacy will be involved, but the gamut also should involve the nurses because they are also using the drugs, as well as the doctors to look at the therapeutic outcome.
Thank you so much, Dr. Mohammed. So before we close, all the good things, they have to come to an end. So, I just want to request to all the colleagues, because you are the implementer in the field, that the certain key issues, in fact, the messages which Mohammed has brought out. One is that having somewhere the reporting and learning system, and it becomes more important with the focus being on the ambulatory care gradually increasing. So we got to be, in fact, the extra vigilant, and somewhere the education of the families to the communities is going to play an important role. Please start at least the practice of undertaking the prescription audit. That let's make some beginning. There are challenges, there are difficulties, but we have proved ourselves. The system has proved during this COVID time its resilience and rising to the occasion when the country demanded last year in the month of March, April, when the situation started deteriorating. So with this message, once again, I want to thank such an eminent and very, very, in fact, lucid presentation and certainly very clear-cut takeaway messages for all of us at every level, starting from NHSRC lower down. So thanks very much, Dr. Shubhjyoti.
Thank you, sir. Thank you. Thank you for the invitation. I'm really honored to be part of your initiative, and I wish NHRC a lot of success in days ahead. So keep doing the good work, sir.
Thank you. Thanks so much.
Thank you, sir.
You may stop, please, Eco India.
Neha?
Thank you, sir. We are just closing it. Thank you.
Thank you. Thanks for all the support.